Well, welcome everybody today to ICMDA webinars. I'm Dr. Peter Saunders, the Chief Executive of the International Christian Medical and Dental Association, which brings together around 60,000 Christian doctors and dentists in over 80 countries of the world. And today our topic is family medicine training in resource-poor settings. And our speaker is Dr. Rebekah Zechariah, who I will introduce very shortly. So it's my pleasure to introduce a dear friend, Dr. Rebekah Zechariah. And Dr. Rebekah heads the Distance Education Department at Christian Medical College in Vellore, India. She's a geriatrician by training, and she's always had a passion for teaching and had the God-given opportunity to be involved in medical education right from the beginning of her career. She completed her master's in higher education and has been involved with CMC's distance education team since early 2015. And one of her focus areas is enabling learners to understand education as a whole and being able to equip others to teach and to learn well. She's grateful to God that she has an excellent team to work with. I can vouch for that, who with the Lord's help are able to run many courses and training programs on a blended learning platform in India and globally. And if you don't know what blended learning is, you are about to learn. But really the flagship of all of these courses has been the course in family medicine that we're going to hear about today. So Dr. Rebekah, you're very welcome with us today, and I'll hand over to you. Thank you very much.
Thank you so much, Dr. Peter and Josh and all of the other ICMDA team members. It is truly a privilege for me to be able to be a part of this. I have attended a few of the previous webinars as a participant and have really gained much, and I'm just humbled and honored to have been invited to speak at one of the webinars today. I will take us through just a journey into family medicine training with a particular focus on looking at lower resource settings, countries with lower resources. So as Dr. Peter mentioned, I have the privilege of working with a team in Christian Medical College Vellore, the distance education team. And we have been running training programs for health professionals for the last 16 years. And like Dr. Peter mentioned, although we have several courses, our flagship course is our family medicine training program, which is the oldest course and has taught us much. And we have built on other trainings from that. And so today I'm here to talk to you and also engage in a discussion through our Q&A about family medicine training in lower resource settings. So that's going to be the focus of what we're talking about today. And I just want to begin with a few introductory slides, which I'm sure is very familiar to most of you here, either because you are a family physician or you are involved maybe in GP training or some aspect of it. I'm sure that's kind of what has brought you to today's webinar. So just beginning with looking at family medicine as a specialty. I remember a joke when we were kind of talking to one of our group of student doctors saying, what is family medicine? And there's so many different versions of it, definitions. Somebody even asked once if family medicine was the same as family planning. And so there is a very wide and diverse understanding. Some of it is good, some of it maybe not so good. And I think it's important to kind of just clarify every time we get an opportunity. So this is not family medicine. I just thought this cartoon was kind of funny, where the doctor is here to see a patient with his whole family and said, didn't you know that I'm a family practice physician? That is not family medicine. And this is just probably one of the best definitions that I found from one of the fathers of modern family medicine, Ian McWhinney. And this is from an article in the New England Journal of Medicine back in 1975. But it is really a wonderful description of what family medicine is: an academic and clinical discipline focused on the provision of continuous, comprehensive, coordinated, and contextualized primary health care for individuals, families, and communities. I know that's a pretty big definition, but I think really the words to focus on there are that it's continuous care, it's comprehensive, it is coordinated, and it needs to be contextualized for the community that we serve it. And really the focus is on primary health care. It does not mean that family physicians do not serve in secondary or tertiary care settings, but they usually are the first point of contact for a patient and the family and the community. Looking at family medicine as a global need, this is actually new to me. And I'll tell you why in a few minutes, but we have a wonderful partnership now to be able to take the family medicine program that we have onto a global platform. And I have been learning so much about what the need is and trying to understand this from a global platform. So I came across an excellent article in the Canadian Journal of Family Medicine. And I just want to use that article as the base for what I'm going to talk about here, a global perspective. This article just broke it down into regions and talked about what is the health system in that region, what does family medicine look like in that region, what does training in family medicine look like, and what are some challenges and steps moving forward. Clearly, I can't go into all of that in 25 minutes, but I'd just like us to just look at just different regions in the world and maybe see one or two points that stand out with respect to family medicine. I'm not going to go into what the health system in the regions are. So if we begin by looking at North America, Western Europe, and the Oceania region, I think these are probably the regions where family medicine is most well accepted as a specialty and is integrated into the healthcare system. Apart from North America, in the Western Europe and Oceania, from what I understand, the family physician, otherwise known as the GP or the general practitioner, serves as the gatekeeper, serves as the first point of contact for an individual, his or her family, to actually be able to access healthcare. Training in family medicine is also pretty strong in these regions, with specialties ranging from anywhere between 2 years to 5 years of training. In places like Denmark, I understand it's 5 years. And they are also trying to standardize the training across these regions. Let's look at Latin America. It was very interesting to learn about it. I think if you are a family physician or have an interest, you will know that Brazil is probably one of the top models from Latin America that is talked about. Brazil has a model where family medicine is actually practiced in the community, what they call as community-oriented primary care, or COPC. And the health system is actually so beautifully kind of looked at through this lens of COPC. Other countries in the region are beginning to accept it. In fact, from what I read and learned, almost every country there has some sort of family medicine training, but it's still very little, not a lot of people who might be interested in taking the training because I think they are not aware of what the specialty holds. And Honduras is the only country that I read where actually there is no formalized family medicine training. The other regions do have some. If we move from there to sub-Saharan Africa, we see that it is very wide, very diverse. South Africa is probably, once again, one of the countries with the strongest family medicine model as far as training and even healthcare delivery. It's also really nice to see that there are some organizations like Wonka Africa and the East African family medicine initiative that are trying to talk more about family medicine and really push the need for training. Accreditation across education boards in the sub-Saharan African region is also of importance for it to gain recognition. Moving here to Middle East and North Africa, one of the things that I read is that there's a lot of fragmentation, but it is one that is accepted by the health system there, even by the government. That family medicine is something that they would like to have more of. It's interesting to know that there was a survey done, I don't know which year, 2011, where it showed that there are 31 programs in family medicine in the region, and yet, I'm sorry, I'm getting that mixed up. That is in Russia and Central Europe. When we look at Middle East and North Africa, just looking at my notes, contextualization is once again probably the greatest challenge. Moving to Russia, Central and East Europe, so that's the region I was talking about where the government is actually wanting to do this. There are several programs, but very few residents in the training program. So a very low ratio of a family physician to the population. And then finally coming to Asia, which again is very difficult to kind of put it all together in one bracket. But in Asia, I think what's important to note is that the population is mostly rural with several different ethnic groups. And the Southeast Asian countries, Singapore taking the lead, do have some family medicine training. China is really looking at developing more. And then in India, there is a push for family medicine doctors, and I'll get into the Indian story in a little more detail because that is what we are a part of, and that's the program that we've been running here in India for several years. But this is just for us to understand a global context. Now, the DEDU story is really the Department of Distance Education right here at CMC Vellore. And I just want to give a little bit of background of the department as well as the family medicine program. So this picture on the left is just our college campus, just a part of it. We are the second biggest medical school in the country here with every specialty that is available, every possible training program that we can think of. And the Department of Distance Education is probably one of the newest departments. It is only 16 years old in a 120-year-old institution. And so you can imagine the questions and the push that was there when the founder of this department was actually trying to establish this. And the founder is none other than somebody who I think many of you in this meeting here would know, probably even personally, but Dr. Vinod Shah, who was the previous CEO of ICMDA just before Dr. Peter Saunders. Dr. Peter took over from Dr. Shah. He is the person who actually, after working for several years in different parts of India, especially in rural India, came back to his alma mater, CMC, and presented this vision about wanting to start a 2-year distance course in family medicine because he saw this as probably the greatest need in primary care for India. He noticed that there are so many general practitioners. Now in India, when we say general practitioners, it is not the same as a GP in the UK or Australia. It is not somebody who has had training in family medicine. It is a doctor who has finished medical school, graduated, and then you are able to go ahead and start doing clinical work. And we have thousands and thousands of GPs like that who over the years have continued to do clinical work without really an opportunity of specializing further or an opportunity to even have some sort of continuing professional development. And it was Dr. Shah who saw that these are people who need hand-holding, who need upskilling, But how can we provide that for them where they are? Because they're not going to be able to leave their practice or their community or even their families and come to CMC or any other medical school for a residential training program. Now, this is something that I think may be similar in other countries as well. But these two pyramids are what I like to call as the grave mismatch, where the distribution of health professionals, and the numbers I have here or the percentages I have here are about doctors, but it's very similar even if you look at the nursing cadre or allied health professionals, that the distribution of health professionals is almost the reverse or the opposite of the distribution of population. So we have about 73% of our population living in rural parts of our country, with only 20% of health professionals there, and vice versa. And so the question was, how do we address this need? To add to that, the other thing that we see here is that for those of us who practice in maybe a clinic or a hospital or even a large academic setup, what we see is only the tip of the iceberg. So this diagram was drawn by one of my colleagues several years ago, which represents it really well. That if you had 6 children who had severe diarrheal diseases, there's only one who will make it to the hospital. And along the way, there's going to be at least 2 kids who die because they have not had access to any treatment. There's a lot of people who claim to be professionals or even magicians and other sorts of interventions, and people tend to go to them before they actually come to a clinic or a hospital. So these are some big challenges: the inadequacy in training, the excessive referrals. That is something that also is growing in the country. And so the general practitioner, the GP, really finds himself or herself to be just like a triage doctor, not feeling skilled, but just being there to kind of refer almost everybody who comes. A patient comes with a headache, I send him to see a neurologist because that's what he or she wants. Somebody else comes with chest pain, I send them off to the cardiologist. But as a GP, I don't feel adequately skilled to be able to address their needs. And so the vision and the dream was to take education to these health professionals where they are, to their doorstep, rather than have them leave their service areas and come for training. And so that is where the idea of blended learning comes in. Now, we are called the distance education department, but that is really a misnomer because it is not distant at all. Our students may not be with us, but we try to make every effort to stay connected. So when we think about blended learning, which I'm sure many of you here have at least heard about the term, it has 2 main components. And I want to quickly just touch on these without getting into too many details. But the 2 main components in a blended learning program are self-directed learning, which nowadays is really in the form of online learning. It could be in the form of printed books, which can be shipped to a student, which is what we were doing till about 5 years ago. And the second component is face-to-face learning, where during the training period, for a few days, the students are brought together to one of our regional contact centers. And we as faculty or facilitators travel to those centers, spend time with them, and really get to know them better, understand their challenges. It's also a time to do hands-on skills. There are certain things that cannot really be taught optimally on an online platform or a distance platform. And so this is the time to kind of strengthen those skills. And more important than that, to really be able to talk about values and why we practice medicine the way we do. We get asked this question all the time. When we talk about something like rational drug prescribing, we have doctors who've been practicing for 30, 40 years who say, we were never taught this at any point in our medical education. And so it's a privilege and an opportunity to be able to do that as part of this course. So our family medicine course, like I mentioned, is a blended course, 2 years, And what you see in these little boxes here are the different modalities which are used in order to do the training. And with the advancing technology, and with technology actually being more available, even in rural parts of the country, it has been easier to actually connect with the students. The whole of last year through the pandemic, we did not have to stop any of our training because of this format or because of this way of education. Now, the self-learning modules, which are the online modules that have access, that the students have access to, they are extremely interactive. They are not like a traditional textbook at all. They are modules that actually speak to a learner in the absence of a facilitator or a teacher. And I will just show you a few snapshots of that. The picture that you see here is actually just pages from one of our family medicine textbook. We have been doing print version all this while, but with the start of our international program, we have had to take all the material and convert it into online modules. Other courses that we run, like our geriatrics course, our mental health course, we started off on an online platform. And it's been really interesting to see how we can take the technology and really use it to its optimum to provide this type of training. So this is again a snapshot from one of the online modules. As you can see, this is a module on delirium, and every module begins with what we call as a roadmap, which gives the learner an idea of what I can expect in this module. So it begins with what are the objectives. We have a few trigger questions, which really just gets them to think, what do I already know about this topic? So it's like a little quiz they take. Then we move into the main sections. And every module has what we call as an Indian scenario. Now for an international course, we have a global scenario, and then we move into different components. In between, we have something called take a break, where the learner stops, answers a few questions in the form of a quiz, which helps them to kind of reinforce the learning. Have I understood what I have read so far? So as you can see, it's extremely interactive. It's not, if I were a busy practitioner working all day in my clinic and then come home and have family responsibilities, and after all that at 10 o'clock in the night, try to open my book to read. And if it looks anything like a Harrison, with all due respect to Harrison, I've had to study it myself when I did medicine, but I know I will be asleep in 10 minutes. But if I have material that kind of talks to me, I'm going to be more engaged. And so that is the goal of the way these modules have been created. This is just an example of a trigger question. Here's another one. And the huge advantage here on the online platform is we can provide immediate feedback to the students. They're able to know not just what I got right and wrong, but why I got this answer wrong. A little explanation that tells us, like what you can see on the screen over here. So that was the online or the self-learning component. The other component that I mentioned in blended learning is face-to-face learning. And this is where we reach out to like-minded mission hospitals across the country and have partnered with about 25 different hospitals, and they are our contact centers. And so in the family medicine course, which is for 2 years, we have 3 contact programs, each one lasting for about 10 days, where we bring the students to one of the contact centers, which is geographically the closest to where they live. And then we all travel and spend those 10 days with them, doing the training, the teaching, the interacting. So this is just a map that kind of shows you. And so this decentralized approach is extremely crucial for the second half of the blended learning model. So here's just a few pictures. You can see, students in a room here. Here they're doing small group discussions, lots of interactive things that happen. And we have a student support desk and a research desk back in the office. This is a skills lab. We try and set up small skills labs in every contact center with just homegrown models, nothing too expensive, things that we can find even just locally to use for teaching some of the skills. So every module is built with a problem-based approach. They're not according to organ systems, but they are not topical. They are, We have modules that talk about fever or shortness of breath or cough, because that is the symptom that a patient is going to come to see you or me. They're not going to come to me and say, I think I have pancreatitis, but they will say, I have abdominal pain. So all of the modules are problem-based approach modules. So far in India alone, we have trained a little over 3,000 general practitioners across the country over the last 15 years. And I just wanted to show you some feedback. Now this, what you see here is just one way of analyzing it. This is at the end of a contact program. As you can see here, this is the list of the centers where we run the contact program, and we give them a feedback form at the end of each day. Just simple questions. What did you think of this session? Did it meet your need? And then at the end of the 10 days, we collated and kind of were able to understand, which were the topics they really liked the most. Where did a student need help? Which center is a little weak and needs more strengthening? And so this is just a student feedback that has been collated after a contact program. And this, what you see here, I'm not going to read this, but I'll leave this on there for just a minute or so. Before graduation every year, we ask them to send us just a write-up on their learning. And I've just literally extracted phrases or sentences from the several student stories that we've got about how this has made them more competent. They're able to listen better to their patients. They've been able to take learning to a higher level. It has broadened my perspective of family medicine from disease to person. And I just love this. Somebody wrote, not to be served, but to serve, which is a kingdom principle that they're taking from the course. And all of it put together, what we see is that it gives them confidence. It makes them more confident in their practice. They don't just feel like triage doctors. They are now able to resolve more on their own with God's help and refer less and appropriately. Moving on to kind of the final part of my talk here, and I think this is probably the most exciting part, is taking the learnings from our Indian story, from the Indian program that we've been running for almost 15 years now. We have now been able to move this to a global platform. And as you can see, the three logos up here, this is a tripartite partnership with ICMDA, Loma Linda University, which is a Christian university in California, US, and Christian Medical College, to take this program and provide a similar program, but with contextualization for other regions and other countries in the world where there is a similar need for training in family medicine. And so it took us about 2 years to kind of just think about this, what's our goal, what's our aim, what's our reach, who do we want to really serve through this training. And finally, in May of 2020, last year, so just about a year ago, we were able to launch this course in the middle of a pandemic, which is nothing short of the Lord's doing, with this aim to really take this training across to the developing world, equip general practitioners professionally and spiritually to serve their country with a special focus on the poor in their country. So here are our three partners, and just quickly to tell you the role. So ICMDA kind of with their chapters all across the world are able to coordinate, able to contact different regions, set up contact centers, and also be involved in the administration of the course. CMC, we are the education partner. So we have been able to take the material and with the help of others, contextualize it, put it onto an online platform, train people to be able to go and facilitate in this program. And Loma Linda University, they have been strong partners with CMC for many years. They have also been supporting other programs like the PACS program, which many of you may know, or the CAP program. And so they are the accrediting body in this. So this is the role that each of the partners plays over here. Again, the same goal. to strengthen a general practitioner to be able to resolve more on their own, refer less, to be able to look at patient care in a patient-centered, problem-oriented, evidence-based manner. And what I'm going to do now here is I am actually going to play a 3-minute video, which just gives all of us here just an idea of what some of the training material looks like. What are some modalities that we use to train on the online platform? So I'm just going to play a video. You'll see different aspects, and I'll actually be speaking over the video just to tell you what you're actually seeing here. So let's hope this works.
In order to start your course,
so this first bit that you're seeing is what the course looks like when a student logs in.
Module 0, which is
and they have to do a course orientation.
To complete it, click course
so you can see here that they're being instructed to click, to log in, and to enter into the orientation. And they have to go through this. Every module looks like module. This.
Click Start Module to start the course.
Now what we see here is something called Thought for the Month. Where every month when we actually open a module, we begin with a thought,
we don't just speak
asking some of the bigger questions, kingdom principles. So that's what you see one of our faculty sharing here.
The reality of life. And yet there is hope, and that is what we share through the story. Like the starfish, there was one condition. And so for us as people, there is also one condition for this to happen. And that condition is we must be in God, in the Lord Jesus.
Here a doodly video that has been in-house. It explains one of the principles in family medicine. When we talk about the family, we're teaching them about the genogram. Here's another teaching video about neonatal resuscitation. Again, very interactive.
Oxygen is essential for survival before and after birth. Before birth,
it gives the opportunity for a learner to pause, to rewind, to watch it again and again till they have understood the concepts.
From the mother to the baby. When the baby's inside
there might be a multiple pregnancy or hydramnios.
So here's a cartogram that's being
means that 10% of
teaching how to interpret
fundal
it.
height measurements fall below this line. If the measurement falls below the 110.
This is a video that demonstrates how to do a quick neurological exam. The 7-step approach to do a quick neurological exam. Take this template from there. And we have several videos that teach about consultation skills.
In this video, you are about to see a patient consulting with 2 different doctors. Compare and contrast both the consultations. Watch, listen to both the doctor and the patient.
Next. Hello, please come. Tell me, what happened?
Doctor, I'm not feeling okay.
Oh, what happened?
I've been having fever.
Fever, okay. How many days?
For 10 days, doctor.
10 days, okay. So I'll just stop right there. Otherwise, you'll probably find out who's that doctor who's not doing such a good job with consultation. Sorry, just trying to move us to the next slide. So that is just a taster of what some of the training material looks like to engage a student, when they're not with us. It is really important for this training to be relevant to each region, to each country. And so for us, working with partners across the world through ICMDA to be able to contextualize it and make it relevant for their own health system is extremely important. Now, like I mentioned, we are already our first year, our first batch of students. It's just wonderful. We have 29 doctors from 13 different countries who are in the program already and are really engaged and enjoying it. And we have 6 centers, which are our contact centers, as you can see on the map here, the red triangles. So Egypt, Nigeria, Uganda, Cambodia, India, and Pakistan. Unfortunately, because of the pandemic, we were not able to meet with students in these regions and do the contact or the hands-on training. But we were able to do an online version of it and are continuing to do monthly online sessions. And it's really our hope and prayer that things will get better. And in September of this year, we'll be able to meet with them in these regions. There's a lot of interest about expanding this, newer next phases, different countries that would like to come on board. So we're already in discussion with some of the Francophone African countries, with Indonesia, Honduras. And I think it would be our dream, maybe 2 years down the line, 3 years down the line, to also have this material translated into other languages, which would have a much wider reach. And so that's basically an overview, and this is my last slide here, but how can you be involved? And I'd say the first thing is, we ask for your prayers that, we are excited by this, we dream of this, and we want this to grow, and pray with us. Help facilitate in the program. Any of you with a GP background, would like to train in the program, we offer faculty development, and we would love for you to come on board. Promote the training in your region. Currently, the applications are open for the second batch of students. In fact, the applications actually are open only for a couple of more days till the 14th of March. But there's a lot of interest, and if more people are interested, even after today's webinar, we are happy to kind of keep it open for a couple of more days. Pass this, share this with others. I'm sure Josh and Dr. Peter will share information about how you can access our online brochure and look at the application form. But if you know of people who might be interested, or you yourself are interested to actually be part of this training, we would love to hear from you. So I think I'll stop there. I have no idea if I crossed 30 minutes or not. I probably did, but thank you so much for this opportunity. And I will take questions, and with God's help, try to answer them. So over to you, Peter.
Thanks very much, Rebecca, and we're in good time at the moment. So let's move to the questions. And first of all, Dr. Rebecca, from Kirsty Nordpol, from someone in the early days of my family medicine career, would you recommend to finish specialist training before thinking of contributing to training and service in resource poor settings?
Thank you for that.
She's from Scandinavia, I think.
Okay,
yeah,
that helps.
So from Western Europe, she's asking.
Okay. I think from what we saw even earlier in that paper about how there's so much diversity in family medicine, there's no one size fits all, but then the basis is to be able to kind of provide that continuous coordinated care. So, if you're early in your training, you're welcome to kind of probably come on as an observer and see how training is being done in other regions, which may then, as you finish up your training, which may then, kind of spark your interest to be involved.
Thank you. From Sherry Falkenheimer, who you know from CMDA US.
Yes.
And Sherry says, in quite a few countries such as Russia and the Balkans, GPs mainly seem to serve a referral function, and they're very limited in their scope to care. Is there a serious effort in these countries to have them do the full range of what we consider to be family medicine?
Thank you for that question, Sherry. I didn't have time to mention this, but you're absolutely right. In Russia and the Balkans, actually, pediatricians are GPs, obstetricians are GPs, and there's not a lot of takers for family medicine as a specialty, although there are many programs. So I think we don't have training in the region yet. We would love to, but I think we would probably need to find a few champions in the region and see how we can promote it.
Thank you. So Deepak Vargas is asking, could we have the link to the full paper that you gave the stats on the worldwide picture from the Canadian paper you mentioned. And
Sure.
I can probably answer that. Rebecca will give us the URL and we will make sure that it's in the letter we send you tomorrow morning. Thank
Yes,
you.
happy to do that.
Tim Southwood is asking, can you comment on the role of traditional Ayurvedic practitioners in general practice in India? Do they have a part in your program and more widely in family practice?
Thank you for that question, Dr. Deepak. We get asked this often because in India, when we look at the health system from like the government's point of view, they don't really make any differentiation between what is known as Ayush practice, Ayurveda, Unani medicine, several other alternative medicine, and allopathic medicine. However, for us in the training program, we are not at a point where we know enough about what training they have already taken in order to be able to take them on board. So currently, we're not training doctors in the Ayurvedic medicine line, but this is a question we've been asked and something that we are thinking about. What should we do?
Thank you. So Emma Hayward, who is a family practitioner in the UK, how do you recruit participants? And maybe first talk about the Indian program, which has been running a lot longer, how you recruit people for that. And then secondly, the international program as well.
I just want to clarify if Emma's question is about facilitators to kind of help teach on the program or students who are enrolling into the program. How do we recruit?
She's unable to clarify that because she doesn't have a voice, but can I suggest that you answer it for both, because I think both will be of great interest to people. So absolutely. First of all, for recruiting students, and then secondly, recruiting facilitators to work on the program.
So with the students, I think it's easy enough because for the international program, we have the information on ICMDA's website, on distance education's website, and we'll be happy to share that. And that can be circulated. So, anybody who has a basic medical degree is welcome to apply as a student. For co-facilitators, that's what we call them, not teachers, for facilitators and co-facilitators. So in the Indian context, what we have done is actually done alumni co-facilitator training. So several of the doctors who finished the program with us who are interested in teaching, we conduct faculty development programs. We also have people from Prime International in the UK. The organization has been partnering with us and we've been working closely. So a lot of GPs who teach in our program, facilitate, come through Prime. And so I think that's another way to be able to join with us.
Thank you. I could just add on the ICMDA side that you can find all the information on the ICMDA website, and we will send a link afterwards to that so you can direct people to where they can register for this course. But we're also very proactive in the way we do it. So we put this information out through our over 80 national movements to the leaders of those movements to disseminate to their members, through our 50+ field workers in 14 regions around the world who disseminate it, on social media through our WhatsApp groups. And we also have a database of over 800 church and mission hospitals throughout Africa and Asia that we send it to, international mission societies who work in healthcare work as well, get told. And then the various Christian healthcare associations like the Christian Health Association of Nigeria or Zambia or Pakistan or whatever, we disseminate through those as well. But having said that, there are still places on the course for this next year. So do encourage people to book by the 14th of this month, if at all possible. So a question now from Doug Lindberg from CMDA US, who's saying, Dr. Rebecca, can you discuss how you approach teaching procedures and surgical skills with an online platform? So I think that's a bit more about the contact programs. What can you teach online and what can't you?
Right. Thank you for that question, Doug. That's kind of always something that we're thinking about. So when it comes to surgical skills or procedures, we do have some basic skills in the family medicine program. What we and really last year, with not being able to travel and conduct our contact programs in person, I think we learned a lot more. But I think if we even take let's say a surgical procedure, and how do we want to teach that? It's got two parts to it. The cognitive part of that skill can still be taught very well on an online platform through the form of videos. And in fact, a lot of students say it's easier to actually watch a video because I can watch it over and over again than actually maybe stand next to a surgeon and watch it. But then when it comes to the hands-on, really nothing can substitute the face-to-face. So when we do contact programs, we focus on the hands-on skill. But some of the really, for example, a quick neuro examination or examination of a certain, cardiovascular system, we even tell them, do it with a colleague or a family member, take a video of it, send it to us, we'll assess and give you feedback. So those are just some creative ways of being able to do it when we are not able to be with them. But the face-to-face part of the training is really vital for that.
From James Smith, do your rural physicians have adequate internet access? Is that a problem? Perhaps comment about India first and then the rest of the world. Yes,
I'll comment about India, and really the rest of the world, I think we're going to learn now. But in India, surprisingly, because this was a huge concern, but surprisingly, what we see is even in rural India, the availability of a 4G connection in a smartphone is just, it's there almost all over. We have very few complaints about internet access. If someone has a smartphone, these modules are available to them even on a smartphone. They don't need to be connected to a laptop. In fact, I always joke and say that there may not be sufficient toilets in rural India, but there will be somebody with a smartphone and a 4G connection. So we're actually pleasantly surprised that most of our students are able to connect. And as we now go global, I think we're beginning to kind of understand that on a global front. But maybe Peter, you can add to that.
I think it's variable, but it is improving very, very quickly.
Yes,
indeed, across Africa. And there's new technologies as well, not just cables and towers, but balloons, loon technology and so on, which is making it available much wider. So the world's becoming increasingly connected very quickly. From John Masasabi in Kenya, it appears family medicine training is not well understood in Africa. In Cuba, the training takes 2 years. In Kenya, we have only 3 universities offering family medicine as a postgraduate specialty, and it takes 4 years. They question the Cuban training due to deficit in basic sciences and a thesis. Is it possible through the various regulatory bodies across the world to standardize the duration of the training and the content to facilitate ease of practice in any country? So I think it's really a question about the different, how much training do you need to become a good family practitioner in a resource poor area, but also behind that, the question about accreditation and what problems that creates and how you're overcoming them.
Mm-hmm. So yes, I think there are 2 parts to it, and I'll take the first one. How much time? So in our experience of running the 2-year program, what we're able to see is that we can cover the most basic skills. We cover about 80 different skills in the program. And when I say skills, I'm talking about consultation skills, procedural skills, examination skills, and 15 modules with sub-modules, which amounts to a total of almost 100 small modules. And we find that this covers, most of our learners have said that this is very comprehensive. They're able to actually take what they read and use it on ground in practice. If somebody wants one area where they want some more training, for example, I work in a place where I see a lot of OB/GYN, then what we do is we connect them with our local contact center, which is usually the mission hospital there, and encourage them to go and spend a few extra months there, maybe 2-3 months, and train in that particular area. But we found that the 2 years has been good. As far as the accreditation, which is kind of the second part of your question, that is a challenge everywhere. We've been running it here in India for 15 years, and it is still not something that the Medical Council of India has accredited. But then again, in India, no distance medical course till today is actually accredited by the Medical Council. So it's not like this is the only one. However, there are lots of different, health is a state subject in India, and a lot of different state governments that have directly approached us asking for their doctors to be trained. So we see that over time, it's gaining its momentum. We have a Association of Family Physicians of India, and about 30% of the members there are our graduates. So there's a voice there that's able to kind of speak even to the central bodies with the hope that someday we'll get accredited. And across the world, I think, we would love to get your inputs on how can we seek accreditation in your region.
You can see how groundbreaking there says 300 medical schools in Africa, but of all the trained family medicine doctors, 30% of them come out of the Vellore training. So they really have been the pioneers cutting the new steps in this program. And people are seeing from the quality of the graduates how useful this is going to be. And so more and more are picking it up. That's the picture. So our approach also internationally has been that sometimes at the beginning it's difficult to obtain accreditation nationally. But by starting the program, people will eventually wake up to this, and we believe the doors will open. And we've certainly seen that happen with the PACS program, which is the Loma Linda program in surgery. So a couple of people are commending you, Rebecca, on the IT and online modules, asking, do you have a dedicated IT department behind you is one question. That's perhaps a quick one.
We do, a really small team, but extremely committed to learning and then teaching us how to do it. So yes, but we do have a team of about 4 members who form our IT team.
And someone's asking a specific question about, do you know where they can get similar modules for radiology? I don't know if you know the answer to that.
No, I don't know the answer to that, but I can, again, these modules were built in-house with just, nobody in our group is actually like an academician. They're all people who've practiced on ground in mission hospitals and have come back with just that experience and trying to put it together. But if I hear of something in radiology, I'll certainly let you know.
So a question from Dr. Masoda. Dr. Masoda is from Goma in Democratic Republic of Congo, and they've been running a family medicine program there in Goma from the year 2000, and they have about 30 family physicians, but they need many more in DRC because the country's huge and most of it is rural. We'd like to be part of this family medicine training program. He says, please tell us more about the process of recruitment, course graduation, opportunities, fees, and so on. I think the short answer to that is that you'll find a lot of that or all that information on the ICMDA website, and we'll send you a link. And I'll personally put you in touch with Dr. Rebecca as well, because this is a link we'd like to build. But anything briefly to add there, Dr. Rebecca?
No, I think that would be, and if there's any particular question beyond what the brochure has, happy to answer that.
Question, Gloria Lamb, do you think the program's good for doctors from developed countries who are considering to serve in developing countries? And so she's really asking, is the curriculum focused on practice in the developing world? And how different is it from what a GP would learn, say, in the UK or the United States or Scandinavia?
I think when we look at the way the modules and the curriculum in this course is built, it would be similar to what a GP would see in a developed world or the developing world. But I think the approach in the lower resource settings is something that there is a focus on in the course. I don't know if that helps.
Someone's asking, is the program, Eunice Yadam, is the program only for those who've had their, I don't quite understand. I think she's asking, is this this is only a postgraduate course, isn't it? You've
So I
got to
think she's
have a,
asking, do you have to already be trained in family medicine to take this course? Is that right? That's the way
she
I'm
might be, yeah.
no, you need a basic medical degree. Like you have to have gone to medical school, graduated, done your internship, and have that certificate. You do not have to have a training in family medicine to enroll in this course.
Gloria Lamb, given the COVID scenario, are there difficulties to fly to contact centres to have face-to-face contact? Perhaps you talk about what happened last year, but also what we're hoping will happen this year.
Yes, yes. So, last year we were supposed to travel and teach in 6 centers in September, and obviously we could not. So we did an intensive online weekend program, and then we're continuing to meet with students once a month, which has been really good. And, God willing, if things get better and travel restrictions are lifted, then we do hope to travel and teach in September of this year.
And sadly, we've run out of time, so this will have to be the last question. As a Christian institution at CMC Vellore, how do you share your faith in the curriculum? How explicitly Christian is it? How's faith built into the whole program? And does that create problems in some areas where there might be hostility to Christian faith and values?
Probably the most important question to end with. Thank you for that question. But I think as a Christian institution and as in this program, as 3 partners coming together for whom this is of utmost importance, we have worked towards building this into the curriculum in a way that it translates into the principles that we teach. So we don't kind of stand there and kind of, say we're teaching this from the Bible, but like what you saw in the video, every contact session, every single morning begins with what we call a thought for the day. 10 minutes to just talk about, one of the bigger questions in life. It is a kingdom principle, but, we don't stand there and kind of say it's from the Bible. Or very often we have students kind of talk to us and just ask us questions like, how come you guys, one of the things we get in India all the time is, how come you are so freely sharing of your knowledge? I went to a medical school where I did my training in surgery, and halfway through a surgery, the surgeon asked me to turn my back so I don't see steps 4, 5, and 6. That's the kind of training I've received. And so I think more than actually having it in the curriculum in words, there's so many opportunities to be able to actually share Christ through that. And we tell them that this is important to us. Our faith is what really leads us to do this training. So it's there. It's pretty much there throughout the training program.
Okay, thank you so much, Dr. Rebecca, for speaking to us, enlightening us about family medicine training in resource-poor settings from your huge and groundbreaking experience, I think, at CMC Vellore in India. And really our hope and dream, working together with ICMDA and Loma Linda, is to see this course really grow and doctors all over the world being equipped in family practice so that they can resolve more and refer less, but also be a Christian witness in their work. So it remains for me just to say once again, thank you so much, Dr. Rebecca, for coming on to ICMDA webinars, to sharing your experience and wisdom with us and answering the questions. Thank you to our 3 translators, Hernda, Feriot, and Michael, for your translation today, to Josh for all his IT wizardry behind the scenes. And so from ICMDA and from me, Dr. Peter Saunders, God bless you, and we look forward to seeing you again soon on ICMDA webinars. Thank you.
Thank you so much. God bless.